Greetings and welcome to this module on antibiotics as weapons and the resistance mechanisms. In this lecture series on antibiotics, we'll discuss sequentially the general overview and antibiotics resistance mechanisms, the types of antibiotics currently on use, and their resistance mechanisms that would have developed. And at the end of this playlist, I hope everybody will be confident in giving an antibiotic to the patient based on the suspected organism. So in this module, we'll discuss about the basic basic antibiotics and its mechanism of actions, the strategies and the rules of administering an antibiotic. So before learning any drug, you must learn how the antibiotic skills. So this is completely for educational purposes. This is medicine beyond Harrison's. Let's get started. So the five fundamental strategies. Every antibiotic does only one of these based on the IDSA lens. It is either the cell wall inhibition or the protein synthesis inhibition or the DNA replication inhibition or the metabolic pathway inhibition or cell membrane disruption. So cell membrane disruption is specific for daptomycin. It is the final salvage antibiotic of use. So cell wall inhibition is the most common mechanism of which we use an antibiotic. It is the bactericidal and the most preferred antibiotic of choice in case of sepsis because it is bactericidal. It is beta-lactams and vancomycin. Protein synthesis inhibitions are aminoglycosides and macrolides based on the 30S and 50S subunit inhibition. It can be either static or cidal based on the dose, duration, and the type of organism that is being targeted and the site of its action. So DNA replication inhibition, such as fluoroquinolones, DNA gyrase inhibition, the most important adverse effect or the drawback of this antibiotic is that it rapid resistance develop to these kind of antibiotics, and whenever you see a culture, it is highly likely that you see it is fluoroquinolones resistance. So because of which fluoroquinolones are now out of favor for usage in urinary tract infections. So metabolic pathway inhibitions are trimethoprim sulfamethoxazole drug, cotrimoxazole. It has a very specific and niche usage in specific situations, and not for all drug. So for pyelonephritis, currently the first line drug is trimethoprim sulfamethoxazole if you are giving it as OPD basis. So once you know the strategy, you can predict the speed of kill, the sidle, the static, the synergy, or the resistance emergence can be predicted once you know the type of antibiotic and the organism that you are targeting. So rules of engagement, IDSA rules of sepsis, what it says is if it is a bloodstream infection, always go for bactericidal that is beta-lactam or vancomycin. So this already excludes macrolides, makes beta-lactams as the king of antibiotics, explains the aminoglycoside synergy. So aminoglycosides by the mechanism of protein inhibition, once the beta-lactam lyses the cell wall, these aminoglycosides can penetrate into the organism mycobacteria and can kill it. So static versus cidal, the truth. Static drugs works in vivo if the host immunity is intact. This is a very important line that when the host immunity is intact and patient is not immunocompromised, static drug will prevent multiplication of the bacteria until and the host immunity can take over. So prefer cidal in ICU setups, neutropenic patients, and bacteremia. So it is a policy logic and it's not a dogma. So myths, there are few myths that you must need to unlearn. These are the myths that you should need to eradicate from your mind. So not always a broader antibiotic is a safer. It's not always that a combination of antibiotics is stronger. So longer is not better. Newer is not superior. So the cephaloxime that was long back discovered is still the king of cephalosporins, third generation cephalosporins. It has the most studied pharmacokinetics and dynamics and the spectrum of action, everything. So it is not meropenem is not the safer choice in every organism when you are suspecting a methicillin sensitive Staphylococcus aureus. So combination is not stronger. So you cannot combine a linezolid with this clindamycin. So similarly, your first pro rule is choose antibiotics by mechanisms first, not by its name. So how it acts is what is important and not by its name. So just hearing the term meropenem, that doesn't signify that it is the best antibiotic of choice. So if you do this, everything else will become the easier in the upcoming module. So how bacteria fight. So this is very important topic. So we have learned the mechanisms of action of antibiotics. So for every reaction, there will be an opposite reaction. From the bacteria, we get a resistance mechanisms that actually matters. So antibiotic choice is not about just the drug. It is about the resistance mechanisms and how the bacteria fights back the antibiotic given. So the five is as we discussed the five strategies, five different mechanisms of which antibiotics act. There is also five types of resistant mechanisms portrayed by the bacteria. So it can be just enzyme production where enzymes can completely destroy the drug. So drug completely becomes useless. So this is the most important cause of resistance of drugs, mainly in the ICU setups. So target modification, the changing of binding site so that the drug can't bind to the target site. Reduced permeability such that it blocks the entry of the antibiotic, leading to its high MIC value, minimum inhibitory concentration, to kill the bacteria. The bacteria can go one step ahead to develop an efflux pumps. These efflux pumps can pump out the drug and it can lead to partial resistance. It can bypass pathways for alternate metabolism. The drug may become irrelevant in these such a cases. The focus here is enzyme mediated resistance explains 80% of ICU antibiograms. So, enzyme production is the most important type of resistance mechanism that we must need to be aware of. Just penicillin is producing, carbapenem is producing. All these are enzymes that are being produced by the bacteria, make the drug useless. So beta lactamases, the main language spoken by the bacteria is production of beta lactamases. These enzymes that cut the beta lactam ring, like now the clinically relevant classes are the beta lactamases produced by the mycobacteria of various types. It can be just a narrow spectrum beta lactam, which is just resistant to ampicillin or amoxicillin. It can be a extended spectrum beta lactam, which will confer its resistance to third generation cephalosporin, such as ceftriaxone. It can be just It can be AmpC producers, so that it can be even resistance to ceftriaxone and also other other third generation cephalosporin drugs. So in these cases, we might need to use cefepime or meropenem. So carbopinamases can be produced by the organisms, which will confer its resistance to meropenem, etapenem, imipenem. So in a narrow spectrum, or narrow spectrum, beta lactamases are produced by organisms such as E. coli, Klebsiella, and H. influenza. These destroys ampicillin and amoxicillin completely. So these can be combined with clavulanate and tazobactam such that it enhances its effect and it can destroy the narrow spectrum beta lactamases. So ampicillin resistance, amoxiclav can be sensitive. So this is not multi-drug resistance, so do not panic. It can be easily treated with amoxiclav. So extended spectrum beta lactam, this is where the most doctors panic and panic incorrectly. So extended spectrum beta lactam destroys third generation cephalosporins, especially ceftriaxone and ceftazidime, aztreonam, sometimes cefepime in variable proportions also. So what ESBL spares is carbapenems. So in case of extended spectrum beta lactamases producing organisms, you can use a carbapenems. You can also use piperacillin tazobactam in specific clinical scenarios where the patient is not immunocompromised, not in sepsis or septic shock, and the minimum inhibitory concentration is less than 4. When all these criteria are met in a ESBL producing organism, you can just use piperacillin tazobactam instead of ceftriaxone or ciprofloxacin sulbactam. Can go for piperacillin tazobactam. If these criteria is not met, then straight away the drug of choice would become a carbapenem. So variable sensitivity because can be used, but it is controversial. Its usage can even lead to the further aggravation in the resistance pattern to carbapenemase producing organism. So whenever you see ceftriaxone is resistant in a culture report, you must jump and go for carbapenem or in specific clinical scenarios such as non-immunocompromised patients, in not in septic shock, non-fatal infections, and a minimum inventory concentration of less than 4. If all these criteria are, then you can go for President Tazobactam. So, do not use ceftriaxone if ESBL suspected or proven, even if lab says intermediate or low MIC. Why? Because the inoculum effect and high failure rates are there for ESBL organisms. So ESBL suspicion is clinical and it's not microbiological. So when the patient with recurrent UTI, rare exposure to cephalosporins, even oral cephalosporins like Cefixime, a recent hospitalization in the past 90 days, ICU stay, diabetes with an indwelling catheter. In all these cases, you must already suspect an ESBL producing organism and can go for a carbamazepine. Or you can start low with piperacillin tazobactam and avoid cefepime sulbactam or ceftriaxone. So AmpC, it is one another class of beta-lactam organisms. These are produced by spice organisms. These are inducible AmpC producers, where these are spice organisms called Serratia, Providentia, and indole positive organisms, and Proteus, Citrobacter, and Enterobacter glauca. All these organisms produce AmpC, beta-lactamases. It is an inducible resistance. It looks sensitive initially to third generation cephalosporins, but later it produces AmpC and becomes resistant to these drugs during the therapy. It destroys third generation cephalosporins and inhibitors. In this use case, if they pay, say, for example, if you see a culture report with Enterobacter coloca, and it is saying that ceftriaxone, it is an AmpC producer. You must know that this organism is an AmpC producer. So in these cases, even if ceftriaxone is sensitive, don't go for ceftriaxone because of AmpC. During the therapy, it can become inducible AmpC producer and can become develop resistance during the therapy. So even if sensitive, in case of an AmpC producing organisms, Serratia, Providentia, Proteus, Heterobacter, and Enterobacter, we use Cefepime initially. Cefepime can be used in an AmpC producers, or you can straight away go for carbapenems. So carbaminoms, these are the nightmare category, mostly encountered by the ICU physicians. So these are various types of AmpC producers where KPC, NDM, OXA, these are the most important varieties where KPC is commonly found in USA, which is carbapenem resistant. NDM India, it is zinc dependent, and OXA 48, it is silently resistant, most prevalent in the Europe. The NDM is most common in India. So there are few subtypes where when in NDM cases we can only go for a there are newer beta lactam with beta lactam inhibitor therapy that are upcoming. So previously in case of carbapenemase resistance, when the report shows meropenem, imipenem, etapinem, all resistance, and it may inadvertently show that ceftriaxone is intermediate or sensitive. Even then, ceftriaxone won't work for these kinds of patients, and you must go for an iron antibiotic such as colistin or tigecycline as per culture reports. So in these cases, IDSA says expert consultation is required. Nowadays, newer third generation cephalosporin with BLA combinations have come with ceftazidime, avibactam, and dastuvamab, which can be used in these cases of carbamase producing organisms. Where when you do a carbar assay, carbar resistant pattern assay, you get these kinds of enzyme, what kind of enzyme that the organism produces. Only in case of NDM producers, you must use a combination with ceftazidime, avibactam, followed by the infusion of aztreonam. These should be combined like 3 times a day dosage. Ceftazidime avibactam comes in a dose of 2.5 grams, which it should be given thrice daily. And avibactam comes as 1 gram to 2.5 grams. These should also be given thrice daily, right after the infusion with ceftazidime avibactam. So the main use of these antibiotics is the avibactam and archonam combination. In view of non-availability of avibactam as a straightaway drug, it is used along with ceftazidime avibactam. So, so in case of NDM, you must use ceftazidime avibactam plus aztreonam, which is a high cost drug, can go up to 1.2 lakhs for a 7-day course. So when you detect a KPC or an OXA48 variety, in these cases, you can just treat this patient with ceftazidime avibactam and can avoid aztreonam. So this will be suffice for these kinds of carbapenemase organisms. But anyways, when you detect such kind of an organism in the culture report, you must have an expert consultation at the required, possibly an ID physician. Prevent further bacterial resistance and prevent mortality. So non-enzyme and decision logics, there are other few mechanisms where target is modified in case of MRSA by penicillin binding protein 2A and vancomycin resistant Enterobacteriaceae. There are reflex pump producers by Pseudomonas. There are reduced porins by carbapenem resistant organisms. So decision map is how the consultants think is that firstly identify the organism, suspect the organism when you do a culture. What kind of organism, what kind of syndrome it is, and what organism that I am suspecting, and based on which enzyme that it might have. See for the exposures previously whether the patient has undergone a ICU stay, recurrent UTI infection, diabetic with catheter. In all these cases, choose a drug that bypasses these kinds of resistance mechanisms or the drugs. So common mistakes is that treating ESBL with ceftriaxone is the most common mistakes that are being happened in most parts of the country. When you treat say a patient who is having an ESBL E. coli with ceftriaxone, it won't respond and invariably lead to death. So treating an AmpC with Bacteriostatic is another nightmare. So AmpC producing organisms we have discussed, these kinds of patients can be treated with cefepime or can go for carbapenems. Using carbapenems just in case is another nightmare. So you never use carbapenems or a broad spectrum coverage without knowing the suspicion of the organism. So lower the antibiotic, the better the outcome. The carbapenems are broadest, but not always the best for that organism. So ignoring inducible resistance such as AmpC, it should also be not to be done. So reading culture row by row is a very important thing that we should not do. Instead, you should read by the patterns. So we have previously discussed that once you see a report, see for ampicillin or amoxicillin. If it is resistance, it is a narrow spectrum beta lactam producer. When you see it is resistant to zone, we can very well say that it is an extended spectrum beta lactam producers. This straight away the drug of choice would become Plus in the specific clinical scenarios that I have mentioned previously, or you can straight away go for carbapenems. In case of an AmpC producing organisms, go for a carbapenem or in specific cases, use cefepime both. You can use cefepime. In case of carbapenem's resistance, these kinds of agents, you must do a carbar assay and ascertain whether it is an NDM producer. In case of NDM producer, go for ceftazidime avibactam astronam combination. If not, then go for just ceftazidime avibactam. In case of when these kinds of agents are not available, the only iron antibiotic that is available is the colistin or tigecycline. So so mental drill is that. So for example, if your culture report shows intraplatar cloacae, even if it is sensitive to ceftriaxone, if it is sensitive to cefepime, it is also sensitive to peptidazolin tazobactam. So what antibiotic will you choose in this case in this organism? So I will answer this question in the next session. Hope you learned something in this module and hope choose an antibiotic for a possible gram-negative infection. Thank you for watching. This is Medicine Beyond Horizons. Let's meet in yet another video.